We rarely blame patients for when they fail their cancer treatment or their asthma treatment or their diabetes treatment. But with BPD, we often blame the patient. And it's just, I think it's inhumane, really. I saw a lot of recidivism in terms of like a lot of kids that would come in to our program would do a lot better, would get discharged, but then they'd come back afterwards. And it got me thinking, like, what is going on? They said it in a way that was supposedly humorous, but it wasn't to me. If you see someone with borderline personality, you just sort of run. And I just thought, like, but what if you had someone with cancer? What if you had someone with, HIV? What if you had someone with other chronic medical conditions that were really suffering? Why would you run, And I thought, like, not only does the patient not know what to do, but we as clinicians don't know what to do necessarily with these patients. I said, okay, we're not going to have locked doors. We're not going to have quiet rooms. We're not going to inject people. We're not going to strap people down. Now, in 18 years, we've had fewer than 4 restraints. We haven't injected anyone. We don't lock our doors. And so what happens is when you deliver compassionate treatment for someone who's hungry for compassionate treatment, they get better. I never thought of writing about self-hatred, except that the people who I cared about so deeply wanted to die. And I didn't want them to die, So maybe it was selfish on my part because I didn't want these lovely human beings to die. And more importantly, I didn't want them to suffer the way that they did. So I thought, maybe I should do a book for therapists. But I realized that they aren't the ones who are suffering. I really wanted to speak to the patient directly. You were not born this way. You were not born hating yourself. You learned how to hate yourself because you had people who taught you that you weren't worth it. And those, unfortunately, were your early experiences. Maybe you want to learn to love yourself deeply. I'm hoping that you do. But at least you'll be like satisfied enough that you can chuckle at yourself every now and then and just say, wow, I really believed that lie for such a long time.
Hello, friends. This is the Hardcore Self-Help Podcast. I'm your host, Dr. Robert Duff. Today, I had the privilege of speaking with Dr. Blaise Aguirre, a psychiatrist, author, and one of the world's foremost experts on borderline personality disorder and adolescent mental health. Dr. Aguirre is an assistant professor of psychiatry at Harvard Medical School and the director of the 3 East Continuum at McLean Hospital, where he spent decades working with young people facing challenges like self-injury, suicidality, and emotional dysregulation. In our conversation, we dive into his groundbreaking new book called I Hate Myself, Overcome Self-Hatred and Realize Why You're Wrong About You, which takes a very bold look at the pervasive issue of self-hatred, which hasn't really been studied adequately yet. It's the first book to really explore this topic in depth, and he offers powerful insights about where it comes from, why it's often overlooked in therapy, and practical ways to combat it. I think that you'll find Dr. Aguirre's compassion shines through in this interview. It's very moving, but also informative and enlightening. If it's self-hatred or negative self-perception that you have that's holding you back, or if there's somebody that you love that you support who's dealing with that, I think you're going to get a lot out of this episode. And as always, if you enjoy this, please leave a rating, share it with a friend, and feel free to reach out to me at duffthepsych@gmail.com if you have any questions for the show, topics, or guest suggestions. I appreciate you listening, and without further ado, enjoy this interview with Dr. Blaise Aguirre. All right, everyone. I am super excited to sit down with Dr. Blaise Aguirre. Dr. Aguirre, thank you for coming on the show.
Well, thank you so much for having me. Tremendous.
What do you prefer that I call you? Blaise, Dr. Aguirre, Dr. A, Blaise?
Yeah, Blaise. I think, when people say Dr. Aguirre in session, like I'm always looking around, like, who's that? So, we're human beings on this planet. We share a lot of common humanity, and Blaise. I do Dr. Aguirre when I'm doing big presentations.
When you have your tie on.
Exactly,
and stuff like that.
Exactly. What's a tie? Sure. Is a tie?
It's a thing that chokes you very lightly.
Yes. Exactly.
Yeah. So we have slightly different accents. What am I hearing in yours?
Yeah. So I can talk like a South African because I grew up in South Africa. But I went to school, an English-speaking school in South Africa, and so my accent is mostly South African.
Okay. A
I've
little
been
bit
in
of a
Boston
blend at
for
this
30
point.
years, but I don't get in Harvard for 25. But it hasn't seeped into the South African accent. Yeah,
Not yet. We'll
not
see.
yet. No. Well,
So I always love getting a little bit of a backstory. So you're a psychiatrist.
mhm.
What do we need to know about you to understand why you got into psychiatry?
Yeah. So I went to when I was 17, and I grew up in a very Catholic home, and my dad thought I needed to go to a good Catholic school, so I went to Notre Dame, and and we stopped at the seminary, and I said, "Dad, how well do you actually know me? Like the likelihood I'm going to become a priest is zero." Um, and but the courses that interested me were philosophy. Somebody told me a joke, how do you get a philosopher off your porch? And I say, well, I don't know. And say, pay for the pizza. There was very little you could do with philosophy. But one of the things that intrigued me about philosophy is they were asking like deep questions. But I started to think about, well, what if somebody was asked this deep question, but they had a learning disability, or they had, some sort of, they had a biological brain disorder, and how would they perceive that question? And then I thought, well, psychology is actually more interesting. But then I saw within psychology, I saw maybe people who had infections or other conditions that impacted how the brain worked. And I was interested in the biology of it as well. So then I thought, okay, I need to go to medical school in order to become a psychiatrist. So I went to medical school in order to become a psychiatrist and not deliver pizzas. Although,
Sure.
maybe not a bad idea these days.
It's good to have a side hustle.
Exactly.
Yeah. So as a doctor, how does that place you sort of within your family? Did anybody expect you to become a doctor? Do you have other medical professionals?
No, actually. So 3 of my aunts were nuns, and
So very Catholic family.
very, very Catholic. Yeah. My brother. So I'm the eldest of 8, and although I consider myself kind of philosophically Buddhist, really. There were certain aspects of Catholicism that I thought were very appealing, but many that were not. My brother, my second brother, is a physician as well. He's a virologist in South Africa and works with AIDS orphans, and somebody who is at the forefront of the COVID epidemic in South Africa. I have a youngest sister. My youngest sister is a PhD in psychology in South Africa and runs a hospital system. So my family had been business and politics and law. And I don't know, being the eldest, I was somewhat rebellious and said, "Screw it! I want to do something else." And but the brain really appealed to me.
Yeah.
In human suffering as well.
There's something interesting about sort of your family tree then, where the generationally, like all of you guys or a lot of you guys had some curiosity about like why things are a little bit messed up, and so you went into different fields related to that.
Yeah, no, I think that's right. Although my third brother is an engineer for Caterpillar, and but still, he when things would break down, rather than having us call the refrigerator repairman or something like that, he'd watch the technician fix the refrigerator, and then he would fix it himself afterwards. So I think that is a common theme, that we interested in how things worked and how things fell apart and what you could do to help.
Yeah. So where did your career in psychiatry sort of take you?
Mm-hmm. Yeah. So after finishing medical school, I came to the United States. In South Africa, as with many countries, and I've lectured in many countries around the world, psychiatry was not very well developed at the time. There were very few places that treated people with mental health issues. They were considered a disorder of will, of a disorder of bad, or a consequence of bad choices. And I wanted to study psychiatry. And at the time, I was reading a little bit of Freud, and I was sort of interested in Freudian kind of psychoanalytic theory. And Boston, especially Boston University, had a very good program for psychiatry that focused not only on the biological elements, the prescribing, but also the self, and having psychiatrists trained in psychotherapy as well. So I did my training at Boston University, and then I graduated and had a job as a medical director of an adolescent inpatient unit. And then in 2000, I came to Harvard and joined the faculty at McLean Hospital, famous for, movies like Girl Interrupted, Susanna Kayson's great book, and I think it's the oldest freestanding psychiatric hospital in the United States. So, so I've been at McLean since 2000, and mostly working with children and adolescents. In 2007, I saw a lot of recidivism in terms of like a lot of kids that would come in to our program would do a lot better, would get discharged, but then they'd come back afterwards. And, it got me thinking, like, what is going on that people are they're getting better, then leaving, then getting worse, then coming back. And it seemed to me that what we were doing is that we were removing the stressor of whatever was happening in their life. And of course they would then get better, but then we were putting them back into the environments where the stressor existed. And it seemed to me that these children didn't have the ability to be able to manage whatever their home circumstances were, and nor were their parents. And that's when I came across something that I hadn't heard of called dialectical behavior therapy, DBT, and which is almost the antithesis, the polar opposite of psychodynamic psychotherapy, because it's rather than kind of exploring distant past and relationships with parents, it's like, here you are, with everything that's ever happened to you, and what are you going to do with your life as it is, rather than exploring it. And it seemed to me very primitive as a way of thinking at the time. I thought like, when are you going to understand, what happened in your crib when your mother took your teddy bear away, and or anger or whatever it is. And I realized that whereas people like the psychoanalytic process, the ones who got better, and at least the ones that I was working with, were the people who were doing behavioral therapies like dialectical behavior therapy. And so in 2007, with the help of McLean Hospital, I opened up a dedicated dialectical behavior therapy unit to treat suicidal and self-destructive adolescents. And since that time, we've had more than 5,000 patients come from all over the world for treatment. So that's the 25-year version in 3 minutes.
Yeah. I mean, very, very important work, very challenging work, potentially daunting for some people. That's kind of big behaviors and things that you're inviting. And yeah, I know you've done a lot of work with borderline personality disorder, a lot of writing and, clinical work. Is that just happenstance by where your career sort of led you, or is there a reason that you gravitate toward that type of work?
Yeah, I had a very, very close friend in South Africa who had borderline personality disorder, someone I was very close to. And I remember when I was told about borderline personality disorder, I went to the library, and my university was the biggest medical school in the Southern Hemisphere at the time, and massive library. And there was, in these hundreds of thousands of books, one book on borderline personality disorder. And it talked about things like projective identification and countertransference and identification with the aggressor. And and like as a medical student, I thought like, what the heck are they talking about? And
Right.
and then,
Very
and when I was
psychoanalytic.
very psychoanalytic, and then when I was with my friend, like it was, I mean, I couldn't see these processes at work, but what I could see was self-injury. What I could see was suicidal ideation. What I could see was a big intolerance of any interpersonal conflict and very big emotions. But I saw a human being who was suffering, and I just remember at the time thinking, in the way in which they were ostracized or rejected, and I thought like, but they can't help it. They're not waking up thinking life is absolutely wonderful. I think I'm going to piss people off today. It's like they were trying their best, but they didn't know how to. And again, when I actually fast forward, when I came to McLean, I met John Gunderson, technically the father of borderline personality disorder, a psychoanalyst himself. And I just saw that they understood borderline personality disorder in a very different way. And but I never, a lot of my colleagues would often tell me, like, if and they said it in a way that was supposedly humorous, but it wasn't to me. Like, I mean, I love dad jokes and I love silliness, but it was like, if you see someone with borderline personality disorder, run. And I just thought like, but what if you had someone with cancer? What if you had someone with HIV? What if you had someone with other chronic medical conditions that were really suffering? Why would you run? And I thought like, not only does the patient not know what to do, but we as clinicians don't know what to do necessarily with these patients. And so, as with anything, psychoeducation sort of helps. But I always sort of thought about my friend who had suffered, so tremendously, and that, and when I got to the States, I still didn't know much about DBT. I was being trained in a much more psychoanalytic, as I said, format, and then discovered DBT and its power to sort of help people heal deeply. And then I could see where the skills deficits of people with borderline personality disorder mapped onto the skills that were offered by a dialectical behavior therapy.
I can see why the differences was appealing to you, right? Because, no hate against psychoanalytic, psychodynamic theory in general, but if that's the only way that you understand borderline personality disorder, it seems to contribute to that stigma. It's something fundamental that's broken in you, but what do you do about that, right? Mm-hmm. And there is this, unfortunately, there is this stigma against BPD among mental health and medical providers, right? There is that, oh, well, that's so hard. They can't really get better. It's very othering. So I really appreciate the motivations there for you.
I think that one of the other things is that because...
Okay, this episode is brought to you by NoCD. Question for you. How do you know when overthinking goes too far? Well, if you're constantly questioning and analyzing every single interaction, if you're caught on an endless loop of what ifs, and if you feel paralyzed by fears of what might happen, if it's eating up hours of your day and causing you a ton of stress, you might be dealing with more than overthinking. These experiences can be symptoms of obsessive compulsive disorder, or OCD, because the thing is, there's much more to OCD than just hand washing or organizing. OCD can manifest in many ways, and sometimes it can be mistaken for anxiety or overthinking. That's because it can look like constant worry, intense fear, and stressful unwanted thoughts playing on repeat no matter what physical or mental actions you try to take to make them go away. Understanding what OCD really looks like is important because there are so many misconceptions about the condition. So although OCD severely affects millions of people, they often don't even realize it. But if you're struggling with similar symptoms, there's hope, because OCD is highly treatable with the right kind of therapy. That means specialized therapy, because other forms of therapy won't work for OCD, even ones like traditional talk therapy. So that's why I want to tell you about NoCD. NoCD provides virtual therapy sessions with licensed therapists trained in a specialized treatment designed specifically for OCD, exposure and response prevention, or ERP. They accept many major insurance plans to help make it more affordable and provide always-on support between therapy sessions. To learn more about NoCD, go to nocd.com and schedule a free 15-minute call with their team. That's nocd.com to learn more and book a free 15-minute call. And if you want to dive deep into the approach that NoCD uses and learn more about it, check out the awesome interview I did with their chief clinical officer, Dr. Patrick McGrath, on episode 406 of the podcast. All right, let's get back to it.
When I opened up my unit, I said, okay, we're not going to have locked doors. We're not going to have quiet rooms. We're not going to inject people. We're not going to strap people down. Now, they said one thing is to have one person with BPD on a unit. But what if you have 14, not only people with BPD, but adolescents? I mean, handling adolescents we should cancel adolescents. I mean, you're going to cancel culture adolescents because they're really difficult to deal with. But if you've got BPD, even worse. But so this is our 18th year. In 18 years, we've had fewer than 4 restraints. We haven't injected anyone. We don't lock our doors. And so what happens is when you deliver compassionate treatment for someone who's hungry for compassionate treatment, they get better. And it's not a surprise. So people are shocked, like, well, wait a second, like, how are you doing this? Well, because you're delivering compassionate treatment. And then, the other day I got a phone call from somebody. I remembered the name, but I couldn't quite remember. She said, would you come out and have some coffee? I was at your program some years ago. And I did, and was a second-year medical student. And the number of people who have gone from being debilitated by the emotional intensity of borderline personality disorder to then take that emotional intensity and channel it into something that is pro-human, pro-life, pro-giving, pro-compassion, and know how to manage their emotions. And now a lot of people, I actually have a couple of patients that I refer patients to, and they have no idea that the therapists that they're going to see are former patients. But it's wonderful to just see that. Now, of course, not every outcome is like that, but certainly we defied the odds of what people were saying about people with BPD. And by the way, if you think about this, if you have a headache and you keep coming to me and I keep giving you hand cream and you think I'm wonderful for giving you hand cream, but you start getting really upset with me because your headache's not going away, and then you start yelling at me, and then I say, Robert, you're being like a really terrible patient. Stop yelling at me. And say, yeah, but you're not helping me, So anyway.
Right, whose fault is that?
Exactly. We rarely blame patients when they fail their cancer treatment or their asthma treatment or their diabetes treatment. But with BPD, we often blame the patient, and I think it's inhumane, really.
I appreciate the background, and that helps me kind of conceptualize how you got to where you are and why you know so much about this. Mm-hmm. One of the main topics that I want to talk about and that you brought up to talk about is self-hatred. Mm-hmm. Can you speak to that a bit? Like, there's an intuitive understanding of maybe what that means, but like, how do you define it, and how is it different from some other things, maybe depression or something?
Exactly. Yeah. So even though, because I think getting the background of how I got to this question of self-hatred is important. So even though so many people have succeeded in our program, tragically, we've lost some. I mean, unfortunately, borderline personality disorder for people who end up in inpatient residential units, suicide rate is very high. Some people say as high as 10%. And so we've had, 5,000 people, and the number that have tragically taken their lives, lost their lives to suicide, is very, very small. It's a fraction of that. But I still thought, I want that number to be 0, not 5 or 10, So what is it about that group that made life so intolerable? And what was it? What was the pain so unbearable that they couldn't cope anymore? And by the way, we tend to judge people with pains that we might understand. We tend to judge people with pains we understand, in a different way. So if somebody has, say, God forbid, a cancer or something like that, you say, well, I can see how if the pain was that intolerable, they would not want to continue living. But with somebody who's got BPD, who's got very intense emotions, imagine psychological, emotional pain so strong that, that life is too difficult on a day-to-day basis. So when I looked at the patients who had tragically lost their lives to suicide, and the patients who presented with the highest level of suicidality in my clinical practice, people who had been in inpatient units and emergency rooms multiple times, etc., they had this thing in common, and it was an intense self-hatred. And so, to your point, it's not, that seems sort of intuitive, like, okay, it's the hatred of the self, by definition, bit of a tautological explanation. But what is this concept of self-hatred? And it is a disdain so profound, a loathing so profound, that of who you are as a human being, that the idea that you should not be around makes a lot of sense to you. And it does so at different levels. The first level is that people like you are a burden to the world and to the rest of society. And the kindest thing that you could do is take yourself out. But also that the bad things that have happened to you have happened to you because you are fundamentally flawed as a human being, that there's something actually really broken about you, that there's some flaw. And what's interesting about self-hatred is that people don't actually see it as a symptom. Because, there are people who say, I've done something wrong, I hate myself. Or maybe you've got an episode of depression and you can't get out of bed and you say, I hate that I can't get out of bed, or I hate myself for that. I'm not talking about transient moments when you are less than satisfied with who you are as a human being. I'm talking about an enduring quality of isness. Like, this is who I am. I identify as male or bi or white or whatever it is. It's part of the fabric of my nature. Like, I am, and so when that is the case, you don't believe that you can change that because it is just part of who you are. That your eye color is what it is, your gender identity is what it is, that these are just who you are. Like, people recognize you for who you are, and part of who you are is this flawed human being for whom terrible things happen, to whom terrible things happen, and is because of this flaw, and that you hate yourself for being who you are. And so and I think it's transdiagnostic. Now, here's another thing is, and I often ask my colleagues this: when a patient goes to a psychiatric interview, and you're a clinical psychologist as well, is that right? Yeah. We ask about questions like, how do you sleep at night? How do you eat? Have you lost any weight? Do you hear voices? Or do you think of suicidal thoughts and everything? We don't ask patients if they like themselves. We just don't. It's not part of our initial diagnostic interview or mental status exam. And when I started asking patients whether they like themselves, some do, quite a few do actually, which is great. Or they, say, I don't like certain aspects of myself, but yeah, I'm okay.
Yeah.
But when you had, first of all, it would shock them. Like, what do you mean? Like, no, I don't
Some
like
people
myself.
laugh. Are they like, of course not?
Yeah, no, I don't. Like, it's like ridiculous. Like, you even, and I said, well, how bad is it? And some, again, like some dissatisfaction, or maybe, I wish I were thinner or something like that.
Sure.
But then there's this, no, I hate myself. Like, the world would be better off without me as a human being. And that's, when I started to see that, and it seemed so intractable, I could stop people from taking their lives. I could help them learn the skills to reduce suicidality, to improve their depression, to reduce cutting, to get involved in better, healthier, physical, romantic, platonic relationships, all of that. But this I could not change. Like this, it didn't shift to any of the techniques that I used. And it just, I don't know, it really broke my heart to just think that these people who I saw as so wonderful and lovable, didn't believe all of themselves.
Does it make you feel emotion thinking about it right now?
Yeah, because I think of, I think of like people in the healthcare profession that I've treated who are now these wonderful, caring human beings, and that for such a long time, they carried this burden of worthlessness, of just like intrinsic worthlessness, of feeling that they deserve all the bad things that happen to them, because that's what happens to bad people. And just to think that, and you know, the other part of it is that the lesson of self-hatred is learned as a very young child. And so what happens is that, you know, they don't know a different world, a world where they're appreciated, but where they can fundamentally appreciate themselves. And yeah, when I think about feeling that way, that about something that just isn't true. Like, I mean, you're not this flawed, horrible individual. Now, of course, if you have the diagnosis of say, cancer, God forbid, and then, you know, and that you're in a lot of suffering, okay, that's the diagnosis that you've received. But no one gives you the diagnosis of self-hatred. It's that you learn that, and then you just believe that it is part of who you are. So it's not, it's like, it's intrinsic. And, you know, one thing is to begin to label it as its own entity. Like, this is self-hatred. Yeah.
Yeah. You mentioned it's people who are experiencing that don't see it as a symptom, and that makes sense. It's not something external that's happening to them. It's a fundamental part of who they are. Therefore, the choices that they base on that are just logical.
Exactly.
Yeah. You mentioned that a lot of times this kind of comes from the past, from upbringing. What have you observed there? What leads to self-hatred versus some of these other cases where there are strong symptoms, but not this fundamental self-hatred?
Yeah. So what's interesting is, you know, I've written, I think this is my 20th book, but
that's crazy, man. That's great.
Exactly. But to me, more like, I would, if I had to just write one book, it would be this one. And you know, more than the DBT books, more than the mindfulness books, and all of that. And so I never thought of writing about self-hatred, except that the people who I cared about so deeply wanted to die. And I didn't want them to die, you know, so maybe it was selfish on my part, because I didn't want these lovely human beings to die. And more importantly, I didn't want them to suffer the way that they did. And so I started collecting stories many years ago. So even though, like, you know, some of the books that I've written, I've done in a year and a half, these I was just collecting stories, narratives as I went along. And there seemed to be this early form of intense invalidation of themselves as you know, children, where maybe there was sexual abuse, physical abuse, a lot of emotional abuse, a lot of bullying, where the young mind cannot contextualize this experience. So, you know, I mean, if you know, if you grow up in the Congo, in you know, in a little village, that's all you know. If you then go to Paris, what a strange world. And so, if all you know is that you're not good enough, that you deserve the things that are happening to you, that you may be being abused physically or sexually, you are learning the message about yourself that you are somebody worthy of derision, worthy of abuse, worthy of neglect. And when you look around you and other people aren't getting this treatment, there must be something wrong with you. It's the only conclusion that you can come up with. And so it's a learned construct, because a child isn't born hating itself. It cannot be. It has to learn to hate itself. And this is a key and critical point, is that it has to learn to hate itself. And if it can learn to hate itself, it can learn not to hate itself. And but it's those early messages. And I think that, why is it that I don't see anybody tell me that they started hating themselves, that everything was fine until they were like 22? Because people at 22 can contextualize things. But when you're young and that's your bubble, that's all you know.
So what do you do with this knowledge, right? So you're aware that self-hatred is sort of this underlying thing for many people. It's its own construct that hasn't been talked about enough. What do you do with that?
Yeah. You know, I remember when, just in South Africa, I was there when HIV/AIDS was coming out. And, you know, or when people were speaking about cancer, they would call it the C word, or HIV/AIDS. That what we did is not talk about it, and which was actually the absolutely wrong thing to do, and that the more we talked, the more we studied, the more we understood, the more we shared information, the more compassion we could have, the more we undid the lies that we were being told about all of these various things. And so one thing to do is to actually talk about it, but why is it that in our initial psychological assessments we don't bring it up? So add it as a question. If we are therapists, let's just add it as a question. If the person says no, then you move on. If the person isn't hearing voices, you don't spend a lot of hours talking about how they're not hearing voices. You just move on, which is fine. And if you're a patient, just to be able to say to somebody, if you're in seeing a therapist, just to be able to say something like, I experience a lot of self-hatred, and and to bring it up. So the first thing is that we have to talk about it. Now, from an observer point of view, you can see someone being drunk, you can see someone responding to internal voices, hallucinations, you can see someone get very agitated, you can see someone maybe nervous and they're bouncing their legs. You cannot see self-hatred. And so the problem is that because people feel it's intrinsic, they're not going to bring it up as a problem. And because there's nothing visible to the therapist, they're not going to ask about it. So I think we have to start asking about it and say, this is talk about fake news. This is the ultimate in fake news, that you are the worst human being on the planet, when there's lots of others that we could possibly point at it. And that you're not. Sort of such a terrible person. But step one is either the therapist or the person themselves has to start seeing this as distinct from, my eyes are not distinct from me, but this construct of who I am is distinct from me. It's like, I am not that thing. That is something that I have learned. In the same way that a child is not born speaking English. If they live in an English-speaking country with English-speaking parents, they're going to learn how to speak English. If that child was taken at birth and moved to France, they're going to learn speaking French. And so they have learned how to hate themselves. And if they can learn to hate themselves, they can learn a different language, which is the language of love, because love comes much more naturally to the human heart than hatred does.
Mm. So how do you do that? How does one start to, let's say that somebody is listening to this and they're like, that resonates, that makes sense. How does one begin to take steps to heal or modify that?
Yeah. Okay. So what I did is in the book, by the way, we were thinking about like, what title should we come up with? And it's sort of like, overcome self-loathing or learn to love yourself and all these things. And when I product tested this with my patients, they said, not buying that book. Like that book's
101 ways to
exactly
love yourself.
Exactly. So then the publisher said, well, what your patients say? And I said, well, they tell me that they hate themselves. They say, I hate myself. So we came up with literally, I hate myself. This is not the book. This is just the cover. The book comes out in a couple weeks. But so what I did is I then tested ideas with patients based on different technologies, DBT, CBT, whatever it was. Okay. Now, so the first thing I tried was there's a tremendous amount of research on self-compassion meditation, and affirmations. And so I said, okay, what I need you to do is I need you to go and do loving compassion meditation. So we're going to try that. And I got more middle fingers than I care to think about, because the idea is like, if your eyes are blue or brown or whatever, it's like, it's intrinsic.
My eyes are green. My eyes are green. My eyes are green.
Yeah, it doesn't matter how many times you delude yourself. Like, this is just another form of delusion. Another thing is that parents telling their children how much they love them didn't change how they felt about themselves. And also, by the way, and sometimes parents will do this. They say, I'm doing this because I love you, or I really love you. I've never had a child say to me, oh my God, I never realized that you loved me. Like, this is news to me. It's like, they know you. Who are you saying that for? Is it for yourself, or, or is it for the kid? And so having somebody else tell the patient, practicing loving compassion. There was the other idea in dialectical behavior therapy. There's this concept of opposite action. So opposite action is that, let us say that you're afraid of applying for a job, because you're scared that you're not going to get the job. So opposite action would be to say, sit down with the application form and do the opposite of not filling it in, which is to actually fill it in. So I thought, okay, can we do opposite action through affirmations, the way that you said, my eyes agree. And it just, again, like, not something that worked. Okay. So I started by asking people when they learned to hate themselves. Now, this was very dissonant, because if I were to say to you, when did you learn you had the color eyes that you had? I said, what are you talking about? I've had them all my life. Like, I am just, but if I ask the question as a learned construct, it's like, you weren't born hating yourself. Maybe your eye color is your eye color, your pancreas is your pancreas, and all this stuff. It's like, this isn't an intrinsic part. You have to learn how to hate yourself. When did you learn that? Who were your teachers? Because they taught you that 1 + 1 was 3. And you believed them to be true until you took a math test and you got it wrong. And so it's like, who taught you, and when did you learn it? And so already it created this idea that maybe this isn't such an intrinsic part of who I am. So what I wanted to do is begin to, like, erode this very tight connection between the idea of self and self-hatred, and like, drive this little wedge between this, and then get them to really struggle with this idea that it was learned, and in the same way that if we hypothesize the kid who's learned English and now goes to France, it's going to take a while to actually learn a new language. So you're not going to overcome it in overnight. But one of the things that started to happen was that when they saw the toxic people in their lives, and I said, well, those were your teachers. Now, do you want to grow up to be like them? Because if you do, then just follow whatever they're telling you. But they're giving you very bad advice, and they're doing very bad things to you. So those are not the people that you want to emulate, because they are the ones who have taught you that you're not worthy, that you're not lovable, and that you're discardable. So that's the first thing. And then, once you're able to make that separation, then I keep adding little wedges to continue to separate these constructs. So, for instance, why are you coming to therapy? Well, I want to get better. Well, why does somebody as terrible as you deserve to get better?
Yeah.
And then why with me? I'm very famous. I travel around the world and write lots and lots of books. You don't deserve me, sort of like point out this absurdity of this idea that they don't deserve to get better, and they deserve to get better and be loved just as much as anybody else, that there are no second-class citizens in this train of life, and then little, why did you brush your teeth? That's an act of self-care, and self-care is a tiny act of self-compassion. And then, what are the behaviors that you do? Who are the relationships that you? What are the relationships that you have that make you feel better about yourself? And what are the ones that make you feel worse about yourself? Okay, now you've felt that you deserve the ones that make you feel worse about yourself. Spend more time doing the things that make you happy. Don't take antidepressants. Live the antidepressant life. Be with people that make you fulfilled. And rather than ones that continue to drag you down, because you feel you deserve the ones that drag you down, because that's what you've learned. But they're bad teachers. They're just you're continuing that bad education. And by bad, I just mean ineffective, unhelpful education. I'm saying, like, be with the people who are able to lift you up, that you feel connected with in a loving way. So it's okay, I find more self-hatred when I do these with these behaviors and with these people, and less when I do with do these behaviors and with these people. So so slowly introduce ideas that are inconsistent, incompatible with self-hatred. And the one other thing is this, and that is thinking about your self-hatred is very, very painful. And one of the things that we know about any kind of painful experience, if you're doing exposure therapy or whatever, is that you have to like experience what that is. And people don't want to experience what that is. And you have to face it. You have to write about it. I actually sent out a list of questions like, when did this start? And who taught you? And what were its consequences? I want people to write about that experience. So to put this concept of the self, which is nebulous as it is, into words. So that's those are other techniques. Yeah.
Yeah. So as you were talking, a visual came to mind. I'm not sure, have you ever seen how they open huge wheels of Parmesan cheese?
Yes. Yeah.
So
I love
they do exactly what you're talking about. They get the little wedge, they put it in, they do one on the other side, they do one on the other side, they do one on the other side, and eventually it cracks apart enough for them to, kind of lift the two halves apart.
Yeah. Yeah. And yeah. But in this case, it's all Parmesan cheese. Over here, what I'm saying is like somebody introduced some cheddar into the Parmesan, and what you want to do is if you remove it, it's just like it doesn't belong there. It's
right.
Yeah,
it's not. Yeah, that's absolutely true. It's not through and through.
Right. Yeah.
Have you seen? So since you've zeroed in on this, since you started gathering these experiences and learning personal techniques for starting to highlight it, have you seen a change in the way that you do clinical work and some of these people that have had that high recidivism and stuff?
Yeah. I mean, first of all, I ask about it as a clinician. I harp on it. I mean, I just say, look, I mean, listen, I'm really good, I say this often with a small tongue in cheek because, I mean, you're this wonderful expert. I say the cemeteries of the world are filled with wonderful experts. I mean, we've got a common destiny here, so let's just get on with the work that you need to do. And I can help with reducing depression, reducing self-injury, reducing suicide. But you have to do this work in terms of self-hatred. And if we stop all those behaviors, which, by the way, you were using as a form of validating the self-hatred. Like if I'm so terrible, I feel bad, I self-injure, I get involved in toxic relationships, I use drugs because I don't like how I feel, which makes me feel worse about myself, but it's okay because I deserve that, So that if we stop all the behavior that is external to you without really examining what your experience is, I can then say, oh, wow, you're doing so much better because you're not cutting, because you're not drinking, because you're not involved in these dangerous relationships, but you're still suffering. And I'm not going to see that. That's your own internal experience. And that's the thing that you have to work on. And so, talk about it. And eventually they come around to the idea. And the other thing is, I love my patients. I really do. I have this sense of a shared humanity in this present moment, and agape love, and awe of who they are as human beings. And it's just painful to see them so self-deprecating. So they're saying, like, I have to tell you, it's hard to love someone who hates themselves so much. It's tricky. I begin to challenge it. Again, it has to be there for it to be challenged. I mean, if somebody is, I think that the ideas can work with, perfectionism, with, kind of self-criticism, but often those can lend themselves to cognitive behavioral therapy techniques. Some of them.
We talk about it more too. We call things out more easily.
Exactly. I'm a perfectionist. Where does it show up? I'm self-critical. Like exactly. not this poor state, this immutable state. Because even when, you asked earlier on, what's the difference between that and, say, depression? When we treat the depression, this persists. Your eye color doesn't change depending on the state of your mood, so it's because it's intrinsic. It's almost its own entity. Yes, a lot of people with borderline personality disorder. Yes, a lot of people with eating disorders can experience self-hatred, but it's sort of, I don't know quite how to classify it because it's its own entity. I mean, it can be a part of these syndromes, but it's also like it doesn't go away when the person is less symptomatic for those conditions.
Right. They're sleeping better. They've gained some weight back. They're not cutting themselves. Cool. Check.
Exactly.
But
yeah,
that's still there.
Yeah.
Mm. How do you suggest, like, let's say somebody is trying to figure out if that's kind of a major component of their situation? Maybe you talk about this in the book. This could be a good platform to kind of talk about some of the suggestions you have for people in the book. But, like, where can someone start to figure out if that's what they're dealing with?
Well, I'm going to say this. I'm going to assume that self-hatred is also part of, like, on a spectrum, on a continuum, in the same way that somebody has mild asthma or somebody has severe asthma, whatever the condition. And I think that the people who I see have very severe self-hatred. And I think, and if you ask yourself, like, do I hate myself? I mean, I think a lot of people would say, look, I mean, I'm unhappy with some things, but I don't hate myself, like I'm looking forward to certain things. I don't think the world would be better off without me and everything. But if you're somebody who thinks that they deserve toxic relationships, hurtful relationships, that they deserve the demeaning behavior from their loved ones, from their parents, from their coworkers, from their peers, if you're someone who, when bad things happen to you, you feel like it's a punishment, you're some sort of karmic justice. If you feel that that because you cannot love yourself, that no one will ever love you. If you feel like you're such a burden to the world, independent of your emotional state, that the world would be better off without you. I think that it's an important question to start asking. Is like, do I really? Is there some self-hatred here? And by the way, the other thing I was thinking about is we as a society market to self-hatred because you're on, like, whatever, you're on any of these social media platforms, you're not pretty enough, your skin's not smooth enough, you're not curvy enough, you're not smart enough, you're not athletic enough and everything. But if you buy my product, you will be better and people will love you. That sort of thing. So I think we also have to sort of think about that. The other part of it is it's more than just dissatisfaction. Sort of like, again, like we can be dissatisfied with our lives, but be relatively content with the friends and stuff that we have. It's sort of the idea that even the people who we are closest to would be better off without us. So
yeah. Tell me a bit about the book itself. So, it's called I Hate Myself. Mm-hmm. What is it structured like? Who is this book for?
Mm-hmm. Yeah, and actually, I spent a lot of time with the publisher asking this question because whenever there were people with self-hatred who would come to me, I would go to my colleagues in my clinic saying, do any of you know how to treat self-hatred? And they were just as surprised as the patients were. What are you talking about? And so I thought, well, maybe I should do a book for therapists. But I realized that they aren't the ones who are suffering. I really wanted to speak to the patient directly, and to the people with lived experience directly. And I wanted to do it also because in as much as the people in my book who had lived experience were absolutely categorically convinced that I was insane, that they would ever feel any better and that this could shift. They believed me about everything else, their OCD, their anxiety, but not about this. because they were so absolutely certain, and because they were willing to trust me as we worked through this process, and they came up with some very, very critical ideas about how to overcome self-hatred over time, and then just tear up when they realize how much they've been suffering. I felt that it was really important to speak to the person who with lived experience themselves. So what I did is, I thought of it like, well, I mean, having written so many books, what's the structure of any book? And then it's sort of like the idea of breaking it down into what is this idea? What is this concept of self-hatred? Including what is the concept of the self? I mean, I do this exercise where I get people to bring photographs from as early on as they have them of every birthday, like 1, 2, 3, 4, 5. And then I say, is that the self? Is that the self? Is that the self? Is that the self? Where's the self that you're hating? And do you hate that little girl who is 3 years old, who is being bullied at school? That little girl who is 5 years old, who is being sexually abused, do you hate her? So where does self-hatred start to come in? Where are you beginning to learn this? So, I mean, so what is this idea of the self, which is already complicated as it is? To this day, we don't have a very good definition of the self. We have ideas about what this is. I mean, you have a sense of who you are, most of us. So defining self-hatred, using narrative, using interchanges that I've had with patients to just like really dig deep into this, understanding how it evolves, understanding how it develops, what are the early roots, and again through examination of how people answered the question, of how they imagined it evolved for them. What the research is, and that was a 3-page chapter because there's very little research on this. Techniques that might work based on ideas from other therapies for certain, for related conditions like self-criticism, self-disgust, other things like that. What doesn't work. And then sort of very specific techniques that you can do that my patients, and I've got like 25 different techniques, because not like, as with everything, nothing works for everybody. If you say go and exercise, one person swims, one person runs, one person walks. Like what works for you? I think about comorbidities. So like, what is self-hatred like in borderline personality disorder? What's self-hatred like in eating disorders? Is it, to your question, is it the same as depression? What happens to self-hatred in those kinds of conditions? I could have gotten into a much, much bigger exploration of self-hatred, because there's a lot of like, self-homophobia and other, conditions like that, or racial.
It's like intersectionality there.
Exactly. And I wanted just to stick with it first. Maybe there is more to discuss at a later point, but for now, just like in the mental health space. And then I actually in the book with I asked ChatGPT, like, how would you treat self-hatred? And then I literally copied and pasted that. So that was the only chapter. This is my first like full disclosure on your show, that ChatGPT wrote the final chapter. I disclosed it.
How funny.
And what it says is like, self-hatred is a horrible condition. You should learn to love yourself, and by doing all the self-compassionate things, all the stuff that we know doesn't work. So I don't think that at this point in time, an entity that doesn't experience emotions is going to be able to solve our emotional suffering, because there's also no empathy. Like, even though its ability to read and make inferences, it's just not going to understand. So I thought that I would end it, given that this is, after all, 2025, and it's the age of AI. So, yeah.
Okay. That sounds like a really, really valuable resource.
Mm-hmm.
I'm curious, so this is for the person suffering, the person who's having that experience. What about people who are on the periphery? You mentioned like a parent saying that I'm doing this because I love you doesn't help. What does help?
Yeah. You know, so one of the discussions I've had with parents. So I've had, as I say, I'm a child and adolescent psychiatrist. I mostly work with late teen, young adults. And when I bring parents in, I've sort of like and explored parenting in the context of self-hatred. There's a couple of different things that I see. The first is that I see like, how can my child possibly hate themselves? I've given them everything that I could possibly give them. And you're in a loving family. And
your life's not that hard.
Your life's not that hard. So, which actually makes the situation worse. Because if I have all these things and I can't be grateful for them, it proves I'm a terrible person worthy of self-hatred. Okay. The second thing is to learn the skill of validation. So, for instance, let's just say that a parent was very harshly critical to their highly sensitive child. So maybe they had two children. Child one played soccer, would fall down, cry a little bit. Parent would say, "Get up, go kick the ball. You're fine." The child would get up, kick the ball, go be fine, and everything was fine. Child two is a highly sensitive child and would fall down and hurt, and then say, "No, I can't get up," and saying, "You're being a baby. You're doing all these things wrong." But that style of parenting didn't work for that child. If you give a child who's not allergic to peanuts, they're going to be fine. If you give their sibling who's allergic to peanuts, they're going to get sick. The fact that one thing worked for one child doesn't mean it's going to work for the second child. So it's to sort of say, can you see how the conclusion that your child came up with is that they were defective? Because if they were more like their sibling, they would have gotten up and gone and kicked the ball. But so that there was something really defective about them. And in the way that you praised the older child for succeeding, all you were was critical. So the child learned not only that it was flawed, but it was deserving of the punishment that they got, and they learned to self-criticize, and they strived to be someone like that older sibling who was so successful, but they couldn't be because they didn't have necessarily the qualities, or if they did have those qualities, strong emotions got in the way of using those qualities. So teaching the parent like validation of how hurtful that would have been, in the same way that, to that child, because in the same way that feeding the child peanuts doesn't hurt one, but hurts the other. Like, it doesn't have to be intentional, by the way. It's not like parents say, okay, I'm going to screw up this kid. But it's just like that behavior actually taught the child that it wasn't enough. And that, and I also sometimes see this, because kids come to us from all over the world and all over the country, so we sometimes see this in kids who are struggling with their gender identity. Maybe they haven't come out as gay, and maybe they're not, or maybe they're gender fluid, or maybe they just don't know who they are just at that point. And maybe the parent is terrified that they're going to have a gender nonconforming kid, and so they become extremely harsh, and you are a boy, you're a girl, this is how you have to wear, and this is how you have to dress. And so it like, it doesn't feel quite right, but it must be because I'm flawed, So, and then of course there's, frank, physical sexual abuse,
Sure.
that, so obviously those are other elements. But it's to have a look at the reaction that when your child is struggling, that if the well-intentioned technique of telling the kid to get up and do something doesn't work, even if it worked for other children, is to then pivot, is to say, hey, maybe my kid is a different kind of kid, you know? That doesn't mean that you give up with expectations. It just means that you change your approach. I mean, driving on the right-hand side of the road is fantastic unless you're in London when you get into a head-on collision, you know? So it's like the techniques that you use under one circumstance don't always work in every circumstance. So it's like really paying attention to that.
Beautiful. I want to move toward wrapping things up with you. This has been a really, really insightful conversation. Before that, is there a challenge, a technique, a message you would like to leave people with? You know, the people listening to this right now.
Yeah. You know, really, if you are listening to this and you are somebody who experiences self-hatred, you were not born this way. You were not born hating yourself. You learned how to hate yourself because you had people who taught you that you weren't worth it. And those, unfortunately, were your early experiences, but they were false. They were false teachings. They were false prophets. They taught you something about yourself that is not true. And, you know, when I see the success of so many people who've hated themselves to go on and do such magnificent things with their life, is that you can rise above that and, but you got to challenge it. And so when it comes at you, just saying, no, I'm not going to buy that story. That is fake news. I'm not buying that anymore, that's not true. Is to really begin to challenge it and that it is not a part of you. It doesn't matter, like no one will ever convince me that it is a part of them. They can feel it as if it's a part of them, but it just isn't. That you can learn, maybe you want to learn to love yourself deeply. I'm hoping that you do, but at least you'll be like satisfied enough that you can chuckle at yourself every now and then and just say, wow, I really believed that lie for such a long time. It's the Santa Claus of the negative Santa Claus. Like it just doesn't exist. But that's a positive story. You know, this one's a much darker story, but it's just as made up.
Gotcha.
Yeah.
Great. Now the book, is it out now, or is it going to be coming out soon?
It's going to be coming out in early February.
Okay.
And we're very, very excited. We're getting a lot of attention, for the book. I'm told that like with many other things, the books get printed abroad, and so it's on a ship on its way to the United States, and it's going to be out in early February. This is just parenthetically, my book, DBT for Dummies, when it first came out, I appeared on some like national TV shows. It was #1 on Amazon for 3 days in a row. And as much as I love that book, and I think it's such an important book because I think DBT is so powerful, to me, this one has the power to heal something that's much, much more fundamental than, like some of the other problems of DBT. So it'll come out in early February, and I think originally it'll come out in hardback, and then we'll move to audio and paperback.
Are you going to do your own audio, or are you going to have somebody do that?
No, I think.
Do you know yet?
I think that they told me that somebody else was going to do that. Yeah. No, it's interesting. I hadn't thought of it. I thought about it when they let me know that, but I think my voice, it can be an acquired taste. Some people like it, some don't. So but anyway, they'll have to get a professional person to do it. So. Yeah.
Fair enough. Well, I really appreciate you spending this time with me. Are there any other places that people can find you that you want to point people toward?
Yeah, I mean, so mostly, my work is mostly with children, with adolescents, really, here at McLean Hospital, and we have residential and day program, and I do a lot of teaching. I created my youngest created a website for me called I Need Myself Book, and where if people can send me a message through that. But
Awesome.
So,
Well, thank you for doing the work that you do.
Thank
and
you.
thanks for spending this time with me, like I said.
Yeah. No, I really appreciate it. I appreciate the questions. I appreciate the in-depth look at it, the non-soundbite nature of it.